Welcome everyone to the Novo Nordisk Network for Healthy Population seminar series today. And today we are delighted to have Dr. Laura Rosella, who will be speaking to us. More about Laura in a moment, but I'm just going to start with a land acknowledgement. So just to let you know, I'm currently in Toronto, which is covered by Treaty 13. We would also like to acknowledge the land on which that the land on which the region of Peel operates, where the Novo Nordisk Network for Healthy Populations is situated, is part of the treaty lands and territories of the Mississaugas of the Credit. And for thousands of years, Indigenous peoples inhabited and cared for this land. In particular, we acknowledge the territory of the Anishinaabe, the Huron-Wendat, the Haudenosaunee, and the Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. We are grateful to have the opportunity to work on this land, and by doing so, give respect to its first inhabitants. Personally, this land has provided me with a place to live, work, and raise my family, and I recognize that this privilege comes from the stewardship and care of the Indigenous peoples who have lived here for millennia. Welcome, everyone, and thank you once again for attending today's Network for Healthy Population seminar entitled Considerations for Advancing Population Health, Diabetes Prevention, and Diabetes Management Through Artificial Intelligence, or AI. And we're delighted that this will be presented today by Dr. Laura Rosella. Before I introduce you to Dr. Rosella, I just want to quickly review some housekeeping items. So we would appreciate our audience muting themselves for today's presentation. There will be opportunities for questions at the end of today's session, and we will be inviting questions both through the chat box or by using the raise hand function. If you have questions during the event, that you would like the speaker to address at the end, please enter them into the chat box. Lastly, please note that today's session is being recorded, and we will make the recording available on the network's website. Now, I'd like you to introduce you to Professor Laura Rosella. She's at the Dalla Lana School of Public Health at the University of Toronto. She also holds a Canada Research Chair in Population Health Analytics and the Stephen Family Research Chair in Community Health at the Institute for Better Health at Trillium Health Partners here in Mississauga. She is the education lead for the Temerty Center for Artificial Intelligence Research, or TCARM, and Education in Medicine. Sorry, that's TCARM, and the Associate Director of Education at the Data Science Institute. She also leads the AI for Public Health Research Training platform, which focuses on establishing an AI workforce in public health. She's extremely well known around the world for her expertise in data science, having authored over 300 peer-reviewed publications. She's also the editor-in-chief of the Canadian Journal of Public Health. So without further ado, I'm going to pass it over to Dr. Rosella. Thank you.
Thank you so much, Lorraine, for that kind introduction and for inviting me to be here today. Just make sure that everybody is seeing my slides okay and hearing me okay? Great. Well, thank you so much. So today I am going to talk about considerations for advancing population health, as well as diabetes prevention and management through artificial intelligence. I just want to state that I have no actual or potential conflicts or disclosures to share. So in the next I guess 40 minutes or so, we're going to talk about just in general how we use data and big data in relation to diabetes prevention and management. And I'm going to set some context specifically for the work that me and my team are engaged with, as well as our work with the network, and not mention anything about AI specifically yet, but then focus on the role of AI more generally. And I know there's a lot of discussion about this right now, and this is something I'm going to spend some time digging into, and of course the challenges and the ongoing risks in this space that we have to manage, and a lot of them relate to our core principles of population health and health equity. And so for conditions like diabetes that are so influenced by the social and structural determinants of health, this is really critical for us to go through. So I lead something called the Population Health Analytics Lab. And what we do is we try and take data from multiple dimensions: social, behavioral, environmental data, We use that data to assess distribution of risks in populations, and then use that to inform better strategies for interventions and resources. And I tend to focus on the public health and prevention side, but also intersect closely with my colleagues that work in the health system. And I like to frame it because this is one of the areas, particularly for diabetes, where it's so important to have multiple strategies at multiple levels. So, of course, if we are interested in improving population health, we can start with individuals. We work with individuals one at a time, perhaps through interventions. And eventually, you could end up with impact at the population level if everyone benefits equally, which we know doesn't always happen in practice. When you come at it from a population health or a public health intervention lens, you're starting with populations and you're looking at those factors that cut across populations, focusing on those, shifting those as much as possible to see population health impact. And really, what we have realized is that the health system, the full health system of the future that thinks about prevention to early detection to treatment, is always working with patients and populations at the same time. And I'm setting this up because some of the AI advances I'm going to cover are more individually focused. The applications that we tend to work on are more population and public health focused, but actually we need both to be able to influence diabetes prevention and management. On the public health side, and kind of mapped onto the type of work we do, it's more closely tied to this concept of precision public health. And I'm going to talk about this later because there's a little bit of tension around this topic. But this is really about taking data from all different sources and trying to collect all the influences of diabetes risk or chronic disease risk. And you can use it in developing predictive models, which I'm going to talk about in a bit more detail, through mapping, and all of that to define tailored interventions. And as I mentioned in that cartoon in the beginning, there are individual applications. And in the area of diabetes specifically, we see a lot of these types of models and approaches, and more using AI, that are pointing us towards who needs to be screened or early detection, treatment responses, and of course on the management and prevention. And I'll talk a little bit more about AI in this space. But the work I'm going to focus on mostly for this talk are the population applications, where you see the use of these types of models to understand burden and distribution of risk in populations for prevention, planning, and priority setting at the system level. And specifically, we develop and validate tools called ports, which are population risk tools, and they are analytic tools that take data to quantify the current and future health system burden to inform actions. And we specifically have a tool known as DPORT, the Diabetes Population Risk Tool. And we started this work many years ago, before AI and machine learning really became popular in the space, but now have adapted to integrate AI into this methodology. So I just want to set the stage of how these types of models are used first before I specifically talk about AI. And we work with a number of health system partners for this work, and from different provinces, also health regions, different organizations. These are just a selected few that have been with us since the beginning. And the point is really to answer questions that come up. And this is just an example of some of the questions that we've seen. Some of them are strictly planning questions. Some of them are about investments for public health interventions to prevent diabetes. And I'll show you a couple specific examples just so people have an idea of how would you use these types of models, why are they useful, and what can they do for diabetes prevention. This is an example of a model presentation, just one slide that we gave several years ago, actually, to Mississauga City Council. And this was in collaboration with Peel Public Health, because we were talking about specific investments in infrastructure for active transportation and talking about the impact, both the economic impact, as well as the health burden of people living with diabetes and its projected growth, which is something that we definitely see and feel in Peel region. This is an example of work we did in Manitoba, so another province where we were really trying to understand the distribution of risk in the population using these types of models. So can we take routinely collected data on populations and say, well, what's the future burden of diabetes going to be? Who's most affected? How can that allow us to change our prevention strategies? And here you see that predicted risks from our model increases with body mass index, which is a well-established and known risk factor for diabetes, type 2 diabetes. But when we overlay the who is actually getting diabetes in the population, the numbers, we see that actually there are a large number of people at what we would call a moderate risk level on this very important risk factor that are getting diabetes. So what does that mean? Well, that means a lesser intensive intervention at the population level actually could have a really big impact. And that's been the case for diabetes for a very long time. And it's one of the reasons that strictly high risk strategies do not actually make the full impact that we want to have on diabetes prevention. It doesn't mean we don't have high risk strategies, but the problem is a lot of approaches to diabetes prevention up until recently, which I think have really recognized this topic, were really focused only on high risk groups. And we were leaving out some small impacts that could be made at the population level that can actually transform diabetes risk in a city like Mississauga. This is just another example of how we visualize this and that point. Again, this was in another province, and it's really interesting because with models like this, you can do this in different provinces, different regions, looks very different. We've also done this work in the US where it actually doesn't look like this. There's a much larger number of high risk individuals in the US who fall in that category. And therefore, high risk strategies in that context actually might have a bigger population impact. So it really is about tailoring it to the population that you're intending to build these interventions for. Just a couple more examples. We've done this also pairing it with costing data, which is really important as we're trying to make the case for diabetes prevention. What is that mix of targeted versus population interventions, and what type of impact would it have? And one in particular that we worked, again, very closely with Peel Public Health, as well as several medical officers of health in the GTHA, was around the impact of the big move, which is basically the health transit and active transportation infrastructure. And we use these types of models to say, well, we know if people are able to take active transit to work or school or substitute short trips, what does that translate into at the population level in terms of diabetes cases prevented? And they're very modest impacts when you think about it. And we have data where this is measured, 15 more minutes a day of walking. But again, at the population level, when you have something like diabetes, where risk is so diffuse across the populations, these have tremendous impacts. So they're really helpful opportunities to use models like this for informing how we think about healthy environments and environments that are conducive to type 2 diabetes prevention. Also have used these models in the context of very specific individual interventions. There's a prevention diabetes, primary care diabetes prevention program. And by modeling some of the impacts of this program, targeting different groups, considering different uptake, we were able to, again, look at this particular impact of this program is mostly focused on physical activity and nutrition coaching, for example, and we're able to look at the differential impact and really help with the interventions rollout across Ontario. Several other examples I want to point out in Ottawa. They've also used our model to be able to look at the impact of their transportation master plan. And we've been able also to look at different high risk versus population strategies and across different populations. So just wanted to set the stage of how we use these particular models. And the distinguishing feature of using models like this in specifically a population health or a public health context. So now I'm going to move to talk about what I'm sure many of you tuned in for, which is really about how does AI fit in? How is it changing what we're doing with models like this, as well as many other types of data-driven models in diabetes prevention and management. So one thing I want to mention is that um, the AI revolution's here, right? It's been happening for many years. And I just want to step back and put it into context. AI, we've had three industrial revolutions, and many people are thinking AI is one of them. So we went from hand production to machine production, thinking about steam power and gas power. We went from the technological revolution, electricity and telecommunications. We went through the digital revolution, computers, before we had the internet. And many people are suggesting AI is the fourth one. We know it's transforming many, many sectors. And its uptake in health, just more generally, has been a bit slower, which is not necessarily a bad thing because there are a lot more complexities with health. But the important thing is that we know that we're generating more data than we ever have before. We have billions and billions of dollars of investments in AI. We have about 80% of most organizations in health sectors say they're actively using AI or thinking about using it in a very serious way. And so it's something we have to seriously consider. And I'm going to talk to you about the role it takes and is making in diabetes specifically. So before I even go into that, it's always important for me to mention that AI is not one thing, nor is it applied one way. And this is important for me to mention because it's very easy to say AI and not be specific on what it means. And so anytime I talk about AI or other people are talking about AI, I like conceptual clarity on what's it actually being used for. And these are four, high level buckets where how you can use AI and what kind of bucket it falls into. And it makes a big difference because depending which one you're using it for, the risks and benefits can differ quite a bit. So you can use AI to figure out what's happening, what will happen. Those are the predictive. Those are the models I was showing you before. Why it happens, which is a causal question. It's much more complicated. And then what should I do about it is sort of the recommendation systems or automated systems. And we have actually very few examples of these in the health context, aside from we're starting to see some operational uses of AI in this space. But mostly AI that's being used in health context is in this first bucket. And it's using different sources of data to tell us something, but somebody, a human, still has to act on that information in a very specific way. It can be patients themselves. Actually, a lot of AI is being embedded in diabetes technology, in the public health space. It's still being used more on strategy, but the decision making is still left with the humans and the professionals working in the space. So the new health data environment that we have now is quite different. And this is a really important context. The methodologies around AI have been around a very long time, but the actual data that we have is what's changing quite a bit. And of course, we have data from electronic health records. I'm going to mention this. We have environmental data. We have data from wearables. And of course, we have even internet sources and many, many other sources of data. These are all data sources that about 20 years ago were just not on our radar. And we weren't using them as actively as we were now. So that's been the most important change with the potential for AI and applications. Not necessarily the methodology, although it's improved, but the fundamental mathematics have been around for a while. But the data being the biggest change, and of course, the compute that goes along with being able to process such data. This is an example of administrative data that's being used, all the health administrative data that we use quite a bit. And some of the examples I'm going to show you is around applying machine learning to these data. And what I can say with these data is you have different ways of thinking about complexity in data. So some of it is through very deep, complex data in images, for example, where we use convolutional neural networks. This particular type of data, where we're taking transactions from people interacting with the healthcare data, is not necessarily complex. But what makes it complex is we have lots of different data sources linked together, and then lots of things changing over time. So when we use machine learning methods have more flexibility in them. They are able to capture these complex data sources in their methodology. And when we take into account all the fact that you have demographic information, you have different types of healthcare data, all captured over time, we can improve some of our models and prediction, which what we've seen certainly with some of the models that we've been doing, which I'll talk about in a moment. The other really important piece, and this is where I think there's a lot of potential, and I'm actually quite excited, is that we know that we are only capturing a fraction of what really truly influences population health, including diabetes. So this figure here from 1991, I like showing it in its original form because it looks sort of vintage, because it is. We've known for decades how important the structural and social determinants of health are on many health outcomes, and in particular for diabetes. But we still have lots of unknowns. We don't measure it well, and it's missing from a lot of our models that we use in health. And it's certainly missing from most risk assessments that we do in healthcare, and in particular for diabetes, which is a major omission. So is there now opportunity to take data from all different sources that we weren't able to use before and actually start to get a handle on some of that complexity? There are opportunities. There are risks. I'm going to talk about those in just a moment, but there are now opportunities to say, well, we can measure aspects of the environment using imaging now. We can look at complex factors like wealth and transitions of wealth over time using some of these methodologies. And so there is an opportunity or theory that if we can capture more of these data, they in fact will more represent all the factors that go into diabetes risk. This is an example, it's an older example now, but there are many, many people working in this space. Obviously, we all know how important the environment we live in relates to many chronic disease risk factors. It's an important area of focus of the Novo Nordisk network and many diabetes researchers. And this is just an example that we're not changing necessarily what we do in studying the built environment, but we're changing how we study that built environment. Instead of taking measurements or using different scores, we're using images to be able to break down different features of the built environment. Now that we have fairly strong mechanisms to do image pattern recognition from the environments. I lead something called AI for Public Health, which is a training platform to build capacity for AI in Canada. We have summer institutes every year. Our last summer institute was squarely focused on this topic. How do we reimagine exposure assessments of the environment using street images? And what are all the things we can take into account that we couldn't before? And how can we use that data in a systematic way to be able, surveillance? It also can feed into prediction models. And so both those applications are happening right now. And I want to mention when it comes to the different types of modeling, I mentioned the sort of surveillance aspect, the prediction aspect. I've showed you lots of examples, but there's also a growing field, and I'll touch on this when I talk about the management applications as well, trying to unpack heterogeneity. And now that we actually have all these data sources together, Instead of thinking it's type 2 diabetes is a uniform condition, as one condition that we need to prevent in a specific way, there are very much, I mean, I know everyone that works in the space knows this, subgroups that are slightly different. And how do we think about that in terms of our prevention? Perhaps we need actually different approaches. And so we're actually seeing some new discoveries with bringing in new data and new technology to be able to do that. And I'll talk specifically about the models I showed you in the beginning, how using AI, we've adapted these and what it actually looks like putting these into practice. So as I mentioned, we've been working with diabetes prediction models for a very long time. And in the last few years, developed two machine learning based models that predict diabetes onset as well as diabetes complications. These models are based on existing data. So this is important because these models can be run on data we have on populations on a routine basis. That makes them much more feasible and likely to be used in practice. And looking at both onset and complications, we're really looking at the spectrum of who should be prioritized for prevention and those that have diabetes, how can we mitigate some of the complications? Type 2 diabetes is very interesting because we actually have very high quality evidence on how to prevent these things. We have high quality evidence on diabetes prevention. We have high quality evidence on mitigating complications. The challenge is always getting those interventions to the right individuals. So these approaches actually work well for that particular challenge. There's lots of other applications in AI and health where we don't have high quality evidence for interventions, and those ones are even more challenging. And so just looking forward, and I'm going to come back to that project at the end when I talk about how we're deploying those particular models. But just looking forward, where there are opportunities now to integrate the complex, unstructured data sources, broader determinants of health into diabetes and population risk assessment. And that's the potential that many individuals are getting very excited about. I also want to mention, of course, the role of AI in diabetes. I'm talking about population health aspects and focusing on chronic disease prevention, but there are many, many, many other applications in the diabetes space more broadly. And of course, we know with continuous glucose monitors and automated insulin delivery, there is a lot of machine learning being used right now in these contexts. And the next sort of generation of this space is really about integrating other information, not just what's coming up on the sensors, but actually all the other factors we know. And this is a very, very dynamic space in diabetes management. And in fact, the future really is about multimodal AI. So I mentioned at the beginning that the AI potential is exciting a lot of people because we can bring in more data. Where AI is not quite there yet, but it's getting quite better, is how do we bring in data from all these different sources? So when we're in a position where we're bringing in wearables, we're bringing in genetic data, we're bringing in population health data, social determinants of health, what can we actually do? And that's when I think we'll start seeing transformational impacts in this space. And the last thing I just want to mention before I talk about some of the challenges and some of the risks that need to be mitigated is the discovery potential. Again, this is not my specific area of focus, but I do a lot of reading on this and paying close attention about how is AI changing discovery in the diabetes space. And there are many people in the diabetes world that work on drug discovery, of course, a very important therapeutic area of diabetes management. And AI is really transforming drug design and drug targets. There's a lot of failure when it comes to developing drugs, a lot of trial and error, a lot of time. So again, not the fundamental process and aim isn't changing, but it's really shortening the time to which targets are more likely. How can we reduce toxicity, understanding heterogeneity on who responds to which drugs, designing trials in a much more efficient way so that we can shorten the time to get that evidence. And they're very interesting. There's a lot of simulation studies being done now with AI. So when you do develop drugs and when of this fundamental science work is happening, a lot of this happens in animal models. We're all familiar with that. There's probably some scientists on the call that do that type of work. A lot of that's happening in computer simulations now. So it's just very interesting that I just wanted to raise this here. It's not the focus of the talk, as we're in this very interesting space where we're upending the way we do things. And from what I can see, we're not changing fundamentally what we're trying to do, but we are shortening the time to some of these discoveries with these tools. That's definitely a possibility that's already happening in this space. So I've talked about why big data is so important for diabetes, why we're even developing these types of models, the emerging role of AI. What is it? Why are we interested in it? What's it enabling that wasn't available before? And now I'm going to spend some time talking about the challenges and some of the concerns that have paused the application quite a bit in the health space. And again, not necessarily a bad thing, but that we actually have to be actively engaged in right now. So I'm going to talk about four in particular. There are more. Just for time, I'm going to touch on these and talk about how they might be relevant and what we need to watch for in the diabetes space. So the first one is the one that you've probably heard the most about, and it's the one we're worried the most about, is particularly in the area of diabetes that's so strongly tied to the social and the structural determinants of health. So we know that the data that we're working with reflects the biases that exist in society, and there are many. And there's many examples here on the side of studies where they've been able to show that, in fact, algorithms can be biased based on biased data. And the worry, of course, is that if we use these algorithms to make decisions, we're going to be propagating these biases. Now, I will say there are methods and approaches to mitigate against this. We're in a very different situation than we were even 5 years ago, where we have much more awareness of this issue. And even some of the regulation and standards in the space are specifically addressing it. But what I always like to mention when we're talking about algorithmic bias, though, it's not one thing, and it's not just the model. I think people focus a lot on the model. In fact, it starts with the data we're using to begin with. And this is not just an AI problem, right? We use these data to do surveillance. We use these data in clinical decision making. The data that are biased, that are going to cause problems in algorithms, are also potentially going to cause problems in the other ways that we use data, even descriptive ways. So it's why it's so important to have that focus on the data, making sure it's high quality, making sure we're triangulating across different approaches to mitigate that bias. And this is where, for those of you working in public health and epidemiology, you actually have a lot of expertise in. So some people coming to the space will ask me, well, I'm not a computer scientist, how can I be involved? This is a great way for people to be involved, actually, if you have a good understanding of data and potential biases in data. And then assuming the data are good or as high quality as they can be and representative, then there's the model piece. And there are actually now much more accepted gold standards on how to assess fairness, how to assess algorithmic bias. And I'm very pleased to say that some of this is actually being considered as part of some of the regulatory process for this. So we're really thinking about it critically, and there's a lot of expertise in algorithmic bias now in all aspects of health and AI. And even just assuming all that is well and good, we really have to think carefully about how these models are being used. And we touch on this in our project, which I'm going to mention at the end. Where's the oversight? Where's the monitoring? This is something that's very different than other forms of evidence in health. Once you put an algorithm into the system can change, models can degrade, certain groups might be affected negatively. So there has to be that oversight and monitoring in place. And that's something that has to be built because it doesn't typically exist in most public health or health systems. To some extent, we have it in post-marketing drug surveillance or other aspects, but it's not necessarily built in the same way or scaled in the same way. So this is really an issue about data models and how models are being used. I told you I was going to mention precision public health, and this, this kind of high level concept, and I've been talking about making population level changes, public health interventions to prevent diabetes. And the concept, borrows from precision medicine, which is now that we have all these rich data, and now that we have these algorithms, we can get really good at targeting the right intervention for the right individual at the right time. And if we take that concept to the population, it's about right intervention for the right population at the right time. And there is tension in this space. And when people first started using this term, there was criticism that we shouldn't add that word precision because it's taking us more into, let's say, biomedical or detailed factors away, and not the social determinants of health, which we know are the major influences of health outcomes. But on the other hand, the counter argument was, well, this is a way to reinvigorate a discipline and actually use this information to better serve those that need it most. And of course, there's no right or wrong on this issue, but I want to raise it because it is a risk in my mind. If we see these AI approaches at just making us more narrow on the high risk, we're going to lose that concept I said at the beginning, which is what we really want to do is shift distribution of risk in population to ensure everybody has a better opportunity in their environments for a healthy life and for chronic disease prevention, which we know is so embedded within the environment. So it's just a bit of a risk as we have these models and we have more and more of them, and they're more nuanced and more sophisticated, that we still remember this idea of trying to shift population distribution. The other kind of tension that's been arising is the idea of discomfort with the black box. And so this is a very common criticism. So we're using AI, great, but it's all a black box. And how do we know really what's going on under the hood? And this cartoon that was published in an article about comparing, traditional statistics to some of the newer machine learning methods is a nice way to demonstrate the tensions here, which is, typically in here they're showing an example of a risk prediction model for diabetes. There'd be this very careful selection of all the factors we know from the evidence that have gone in influence diabetes. We develop and validate this model. We have lots of expert judgment. In fact, this is how we developed the original version of DPORT. We had a very systematic and structured process, lots of checks and balances along the way. But I've just told you that we have all of this data from all these sources. And that idea of sort of handpicking variables doesn't apply anymore. It's very hard to be able to actually replicate that process. And so what we're having are algorithmic processes which can go through thousands and thousands of variables of different types of data much more quickly. And again, there's a discovery potential there. And maybe we're missing things the way we were simplistically looking at them before, but we can't verify them the way that we're used to. So what do we do? And where does that put us? So this is where I think sometimes the black box argument is a bit misplaced, because it's not that in and of itself complicated models are a problem. I've definitely seen people misinterpret even very simple models. So sometimes I think we get a false sense of security by saying, well, I can see those 10 variables, they make sense to me. And that's definitely an important part. But what's happening now in the space is more of a focus on interpretability, explainability, and transparency. So as these models get more and more complex, there are now methods, graphical approaches, lots of different ways to be able to show how the models are being influenced by different terms in the model. And that's really important. You still want experts to interrogate it. It's just going to be done so in a slightly different way, and how the algorithm makes decisions based on that model. And then the most important in my mind is transparency. And I hear this again and again, talking from lots of people in the health field, and it's a very valid concern. Who created the model? How do I know it was done with rigor? Is there third party oversight? These are really valid questions that we've established processes in evidence, in public health, and in medicine to do this. And we need to have that same level of comfort knowing there's full transparency in how the models are created and there's ability to interrogate different aspects. And then that trust will be built. And that goes to my last point, which is how we actually build responsible AI for health systems. And there are at least two aspects to this that both need to happen. And I'll mention in the context of the project that we're working on. On the right, you have the regulatory pieces. And again, several years ago, they did not exist. So it was very difficult to know, are people inbounds or not when it comes to the use of AI. And so there are now formal rules and regulations being built. We see this in Canada, in the US, and Europe. Um, Also, in addition to regulation, which will not solve all issues, right? Regulation tends to focus on the most specific, and at least in Canada, the regulation that's on the table, and this not health specific, is really around very egregious uses of AI. So we want also guidelines and standards in the field, best practices to ensure we're mitigating harm. And maintaining responsible AI practices. And those are starting to come out. There are many now which are out. And if you're interested, I'm happy to share those. And this has been a very positive development, which really helps ease the responsible AI in practice space. The flip side is equally important, and that's making sure that when we develop AI for diabetes, for any health outcome, that we're centering patients, community, practitioners, and operators. So what does that mean? That means in all stages of even what problems we're working in to begin with, how we design them, how we implement, how we evaluate, we have genuine, authentic relationships and input for those with lived and living experience, as well as those who are actually practicing and working with these communities on a regular basis, both in the public health and the healthcare space. And without that impact, without that authentic engagement, it's very likely that risks are going to emerge. A lot of those risks can be identified at the start. And very importantly, we start developing trust and conversation. And there are ways to do this very thoughtfully, even in the AI space. And I don't have time to show all the examples today, but I'll mention just one particular project on those machine learning diabetes models I mentioned before. We have a project that's focused on developing responsible AI for health systems, specifically for type 2 diabetes prediction models. And I just wanted to show you the team because the team's really important here. We have myself, and it's co-led by Dr. Jay Shaw, who's an ethicist. So right from the beginning, we're thinking about ethical deployment right from the start. And of course, we have many valued team leads. Dr. Ibukun Abarinje, who's our implementation science lead, who is an expert in thinking about how we implement digital technology in populations and thinking about equity and ethical impacts. We have Dr. Shayan Guha, a human-centered design expert, who's again expert at thinking about obviously the technology, but how humans interact with the technology. Dr. Jennifer Gibson, another internationally renowned ethics expert who sits on some of those tables defining the standards I was talking about earlier globally. And of course, Dr. Lorraine Lipscomb, who doesn't need an introduction, who's keeping us grounded on the utility of these models, how they can be used, and the real experience for preventing and managing diabetes. So just an example of if to do this responsibly, it's a different team. We're not talking about a team of just AI experts. We're actually talking about a multidisciplinary team that can manage all the aspects of co-design, that engagement, and responsible and ethical deployment. And just to give you an example of what we're actually doing, we're co-designing with different community members. We're the actual deployments consistently being co-designed, and we're obviously evaluating and measuring that. And this is just one example of one of our community engagement sessions where we brought together different partners from the region as well as our team to exchange perspectives. And for a good part of this, we're just talking about what AI means and what does trust in AI solutions mean. Not in general, not even just specifically about the models. And then through different opportunities to look at the models, different information, we can actually have an interactive dialogue about what this actually should look like. And of course, this is just one snapshot, one day, but this is an ongoing discussion. And this is the work that's needed to actually make these models impactful and trusted in diabetes prevention and management. And I think we're starting to see this happen more. But in the initial stages of AI in health, we really were focused on the technology. And there were lots of algorithm development and not a lot of thinking about these other issues. And now we're really starting to see them come together. And I actually feel very confident that we're developing some very strong expertise on all the responsible, ethical, and equity implications of AI, in addition to obviously all the data and technological advances and opportunities I talked about in the beginning. So just to close off, really, there are some important questions. So there's definitely opportunity with new data, with the ability to integrate multiple determinants of health for diabetes prevention and management. I showed you some very practical examples where simpler models can actually really have a big difference in how we think about diabetes prevention and management. But there are some, what, who, how questions for us to continually be thinking about. The first is on the data. One thing that I am always struck by is the level of granularity that's missing on some of the social and structural determinants of health. We're getting a lot better. And as I mentioned, I think there are some opportunities with these different data sources, different streams of data sources to really fill it out. But unless we're measuring the full determinants, we might be missing in our action because we're not thinking about capturing all these factors. The who it applies to is very important. And these are the issues around, in any model that we work on, we have standard fairness and bias assessments. We study specifically the performance of models in different groups in the population. This is something we've been doing for 20 years. Me and my colleagues who work on these population models. And when we started doing it, people were wondering because it's not in the sort of standard clinical prediction model to do that. And now it's becoming gold practice. We want to make sure the model works well for everyone in the population. And if it doesn't, we have to know that. And it has implications on how the model will be used. And moving to the how, thinking about once these models exist, is it only a small subgroup that's going to benefit? Are those subgroups already groups that are privileged in the population? This happens a lot in the deployment of technology, especially digital technology, and something that we have to build in from the beginning if we want to mitigate against. So this is my last slide, just to talk a little bit about the future. What does the future look like? Well, I like to think ahead, just to say, well, what does it look like and how can we get there? I do see us, in just seeing how AI has been developing thus far and the rapid pace, that we will get to a point where we have multimodal data. So data from all kinds of different settings, sources, processed and used in real time. And there will be more scale and wide adoption for AI technologies. And it's going to take some time to get there, but it's I'd say it's been developing. I've been in the space for about 8 years. It's been developing a lot quicker than I imagined when I started in this space. So I think we have to be ready and engaged for what that actually looks like. The most important thing, though, is that we're not just using AI for the sake of AI. We're using it in a way that we are seeing evidence of improved outcomes. So, are using these technologies resulting in earlier detection, improved health equity, lower rates of complication? That's the standard we have to measure ourselves to. And certainly that's the standard that we're thinking about when we're thinking about deployment. So, again, there can be a temptation to focus on the technology performance, which is important. But at the end of the day, if it's not improving health equity, it's not improving detection and reducing complications for people at risk or living with diabetes, then we can't be using it. We only have to be adopting the ones that are taking us towards that goal. And as I mentioned, all of this gets smoothed out with mature governance monitoring and oversight. That is not the responsibility of everyone's users. There are individual responsibilities, but there are societal responsibilities. And this is a very active space that's changing weekly. And so eventually, when we are in a better place with regulation and oversight, I think we can focus a bit more on it, on the applications. And last, but certainly not least, in fact, most important, that we're building trust. And those trust comes with engagement, comes with regular conversation and working together. And this needs to be integrated from the beginning. So this is, I think, a shift that we're going to start seeing with AI technology development, and hopefully specifically in the area of diabetes. So I'll thank you so much for your attention. These are just a couple of students in my lab who are doing amazing work at the intersection of AI and population health. And I'll pause now for questions.
Oh, Dr. Rosella, thank you so much for a really insightful and thought-provoking presentation. And I'm going to open it up for questions. Please, does anyone have any questions for Laura? Just looking. Walter?
Hey, hi, thanks. I was looking for my hand and I was going to consider
Yeah.
chatting. Good, excellent talk. Excellent topics. And I was thinking about, the shift in approaches from, evidence-based decisions around, what determines risk, and attached to those are also evidence-based interventions of what to do depending on what those risks are. So now, that's old news. New news is we have all kinds of data on people. We don't really always know exactly what it means or where it's coming from. And that, pops up and develops a new risk algorithm. And we apply that risk algorithm, and all of a sudden, Walter is at high risk for diabetes. But somebody looks at me and says, I don't know why. What are they going to recommend?
Yeah, absolutely. I mean, this is part of the responsible deployment, where we need to get to a point where we need to be able to answer that question. And there are ways to answer that question with some of the new methodologies on explainability. So we can tell you, for example, which factors are influencing your prediction most. And you can have that conversation with a healthcare provider and say, does this make sense or does this not make sense? And if it doesn't make sense, somebody will still have to integrate that information from that model with what they know about you to see if it's still appropriate for us to think about you at risk for diabetes. So it's built into the methods that we shouldn't just be using sort of risk prediction models on their own to say, okay, this means this, therefore do this. I can't imagine a place in medicine where that will ever be appropriate. There's always this massaging of what are you getting from your risk model to what do I know about you and what should we do about you. That needs to happen at this point, I believe, with a human being, a clinician or a provider of some sort who knows how to integrate that. There are people that make the argument that we do have to be open when someone looks at you who objectively you would never be at risk for diabetes and you are, that we may have missed something. And there are people that think that these methods are going to start challenging existing beliefs based on imperfect data and lots of biases that we might need to open up. I don't think that's the norm. I don't think that's going to happen often, but I think once in a while, when some of these contradictions happen, they are about undoing maybe or challenging some very long-standing embedded assumptions about disease progression and illness. And that's kind of the discovery side, which I think is possible, but it's not every time.
Thanks for the question, Walter. We have a question that was just sent to me in the chat, Laura. So I'll just read it. So fantastic presentation and work that you're involved in. Curious to know if anything similar is being done in the type 1 diabetes space in terms of risk prediction, or if your models can be modified and extended for that purpose.
Yes, I'm glad you asked this. There is a lot of active work being done in type 1 diabetes. It's not an area that I specifically work in from a research perspective. But both on the onset side, as well as the treatment and management and the drug discovery side, there is a lot of new AI applications actually happening in all three of those spaces. On the onset side, it's very interesting because as many, if anyone is affected by type 1 diabetes or studies it, there's still a lot of unknowns about why it starts and how it starts and specific subpopulations. We know a lot, but there's a lot more to do. So there's a lot happening in that space. And of course, the automated insulin delivery and continuous glucose monitors. There's a lot of applications and models in that particular space, trying to get ahead of crashes and other aspects that happen in type 1, getting a lot more precise. So there is a lot of work. It's not work that I do specifically, but it's a very, very, very active space.
No, that's great. Thanks, Laura. And I'll just add that there's also some emerging work showing that some immune modulators can be now given to people who with early onset or who have not yet developed type 1 diabetes to help with prevention, which would be really amazing. We have two more questions. I'm hoping we have 2 minutes, so maybe each one can ask one. We'll start with Beju.
Hi, thanks, Laura. That was great. I just have maybe a corollary or a sort of the opposite perspective to what your answer to Walter just was. But I mean, how often are you anticipating that these models are actually going to come up with things that we didn't already know? Like, I mean, I think, we already have a pretty good sense of who's at risk for diabetes. So what's the value add going to be?
Yeah, I agree. And I think not often, but it's probably going to allow us to identify populations that will benefit sooner and get a better understanding of getting the things we know what to do for people that will actually benefit sooner. And I think it will shorten time. I've started to actually think about the main benefit of AI is really just about shortening time of identifying the populations we know we need to identify, shortening time to discovery, shortening. So, and it's a really good point. We don't want to be distracted by AI. We already know, as I said, what needs to be done with diabetes prevention, management, and treatment. We know a lot more than for most diseases, to be honest. Our problem is getting it to the right individuals in the right way in a very complex health and public health system. So that's what we should be using it for.
Sorry, I know it's just 1 o'clock. Maybe Vicky, if you have a quick question for Laura.
Hi, thanks, Lorraine. It's the quickest question. Hi, Laura. My name is Vicky. I'm from Ontario Health. A quick question, maybe the most basic one, is how far away do you think some of this mature technology is? As OH, if we think about when are we ready to implement, we're going to think about those really basic ways of reaching people, like you just talked about. Like, we can send letters out to people for cancer screening. So in the meantime, we're going to be thinking about things like letters. But I love this feature that you're talking about. So how far away do you think it is?
Yeah, really good question. And so whatever it is, it's probably shorter than I think. But we've surveyed a lot of experts in this space, and generally speaking, people believe that in 10 to 20 years, there will be transformational AI, which means like it really fundamentally changes the way we practice. So I'm going to say 20 years, 10 to 20 years, but we can't wait, because if we don't get involved now, the AI that will come in 20 years will not be the one we would have designed. So that's what I always say to people. Even if you're not really interested in getting in the space, get involved, ask your questions about equity and bias, think about how it's actually used for patients and populations, because otherwise what we're going to get is not going to be designed the way we would design it. And I'm speaking as like a, public health and someone that's really concerned about diabetes prevention and management in populations.
Laura, thank you so much. Wow, I'm sure we could have had more questions and more discussion, but we are 1 minute past the hour. So I just want to ask everyone to please join me in thanking Laura Rosella for an outstanding talk. And I want to thank the folks who've joined today and their thought-provoking questions and comments. Please ensure you complete today's evaluation for the session. Lydia will add it in the chat pod. And this is the last seminar of the year. So the next seminar will be on January 20th, 2025, which will be our joint University of Toronto Network for Healthy Populations and Banting and Best Diabetes Center Clinical and Population Health Research in Progress rounds, where we will have 2 of our network graduate students presenting their research. So we hope to see you all there, and I'm wishing everyone a wonderful holiday season that is rapidly coming upon us. So thank you all for joining today. Have a wonderful day. Bye-bye.
Thanks for the invitation.